Okay. Just waiting to make sure it's recording. Good. Okay, we can start. Okay, so patients and I will be presenting emphysema and COPD, a case study. Emphysema is a type of COPD. I just added it in there so that we are on the same page. I will be doing the patient case, and patients will be doing the characterization of the disease. So let's start with the introduction. Emphysema is the disease that we are doing. So emphysema is a disease that belongs to a group of lung diseases known as chronic obstructive pulmonary disease, which is COPD. It is characterized by damage to the alveolar walls and lung tissue, leading to collapse in bronchial tubes. It's a disease of the lungs that generally develops after many years of smoking cigarettes. Asthma and chronic bronchitis also belong to COPD, but emphysema is sometimes regarded as the most destructive of the three. In this case, we will be looking at a patient who was diagnosed with COPD, or more specifically, emphysema. As a result of this, the patient also developed cor pulmonale. With a disease as prominent and deadly as emphysema, it is important we understand it completely and that we know how to test for and diagnose the disease. Moving on to the patient case. Patient X is a 57-year-old male who has a history of smoking. He has recently stopped smoking 2 months prior to this assessment. All in all, he has 40 pack years, which means he's smoked 20 cigarettes per day for 40 years of his life. He struggled with sport as a child and was not active as he aged. He generally lives quite an unhealthy lifestyle and enjoys fast food and watching television most of the time. He has a family history of hypercholesterolemia, which he also suffers from. He's currently being treated for this with simvastatin. 2 of his 3 children also suffer from hypercholesterolemia as well as hypertension, which is also prominent in his family. Patient X also suffers from an abnormal diaphragm and polycythemia. His mother and grandmother on his mother's side have recently been diagnosed with diabetes mellitus type 2. The patient has an elevated body mass index, which is possibly due to his short stature as he appears to be of average weight. Next, we will move on to the patient's clinical manifestations. The patient complained of coughing at night or when lying down for extended periods. Initially, the patient believed it was due to smoking, which is why he quit 2 months before visiting the doctor. As time progressed, he also suffered from fatigue and difficulty breathing on exertion. At the time of this assessment, the patient's cough had become productive. Mucus that was produced was either colorless or white with an unchanging volume or color. He also complained of dyspnea when showering or using the toilet, but not at rest. His chest appeared to be hyperinflated and a slight wheeze was present when he inhaled and exhaled. From the time that patient X first started coughing to the time he was assessed, he lost 17 kilograms with no apparent cause. The final symptom that he complained of was night sweats, which happened every day without fail. Next, we will move on to the investigations that were done on the patient. As patient X has various complaints, it's necessary to perform many different tests to come to a diagnosis. The first step was spirometry, which will show the efficiency of the patient's lung functions. Next, the patient underwent body plethysmography or lung volumes to assess the different volumes and capacities of his lungs. Diffusion capacity would have been done, but due to unforeseen variables, it was not done. During the lung function testing, the patient also underwent a bronchodilator or BD response test, which analyzes the change in lung functions after the use of salbutamol, which is a short-acting beta agonist used as emergency asthma medication. The patient was also asked to place himself on the MMRC dyspnea scale. The scale is used to measure the severity of dyspnea that a patient is feeling. A chest CT was also done to rule out fibrosis and other pulmonary diseases. After assessing the patient's oxygen saturation, evidence that the patient would need to undergo a long-term domiciliary oxygen therapy assessment was found. This was done using arterial blood gas results as well as pulse oximetry for constant monitoring when the patient was both on and off oxygen. Finally, a bronchoscopy was done to assess the internal health of the airways. A biopsy was taken of a mass that was found during the procedure. This is done using forceps that slide into the bronchoscope during the procedure. After all these procedures were done, we can now move on to the diagnosis. The diagnosis of chronic obstructive pulmonary disease was made using the data gathered from the test results. The biopsy of the mass in the airways showed the presence of small fragments associated to mucin, consisting of connective tissue stroma and focal benign mucinous glands. Focally crushed artifact was also evident, which refers to the mechanical crushing of the sample when it is being taken. Unfortunately, this biopsy is inconclusive, and it was recommended that a repeat biopsy be done. The patient placed himself at 3 on the dyspnea scale, which means he stops for breath after walking 100 meters or after a few minutes. This is quite high on the scale and suggests that there is respiratory impairment. Spirometry showed significantly decreased lung functions with an FVC of 30%, an FEV1 of 16%, and an FEV1-FVC ratio of 43%. Keeping in mind that the normal ratio is between 80 and 120%, it is evident that there is severe respiratory impairment here. Lung volumes showed a VC of 46%, an FRC of 285%, an RV of 388%, a TLC of 167%, an ERV of 80%, and an RV-TLC ratio of 82%. Lung volumes work differently during interpretation, and values this high is consistent with hyperinflation and thus emphysema. Airway resistance was shown to be extremely high, but after use of a bronchodilator, there was a significant decrease in airway resistance, which suggests obstruction, which is consistent with emphysema. Diffusion could not be done because patient X had a vital capacity below 2 liters. Blood gases for oxygen evaluation showed that the patient had elevated PCO2, decreased PO2, increased shunt, high carboxyhemoglobin, and low oxygen saturation. Even though carboxyhemoglobin was high, which is evident in smokers, the patient was prescribed oxygen as his saturation was dangerously low. Titration showed that he required 2 liters a minute of oxygen at 16 hours a day. Taking all of this information into consideration, the patient was diagnosed with stage 4 COPD with cor pulmonale as a secondary complication. LT-DOT will be redone after 3 months to ensure that the patient is reacting well and has in fact stopped smoking. I will now hand over to patients to do the characterization of emphysema and COPD.
Thank you, Jessica. Okay, so now we'll be getting into the etiology of the disease as well as the epidemiology. So the risk factors that are associated with this disease is smoking, which is by far the most single clearly established environmental risk factor for emphysema. 8 out of 10 cases are caused by smoking. Chronic occupational exposure from inhaled irritants such as metal fumes, diesel exhaust fumes, mineral dust, organic dust, chemical gases, as well as vapors are thought to be the cause of 19.2% in smokers and 31.1% in non-smokers. Another risk factor is the alpha-1 antitrypsin deficiency, otherwise known as AATD, which is a genetic disorder that is characterized by abnormal production of an AAT protein. The mechanisms of this are not completely known, but it is believed that the low levels of AAT in the lungs allow for the destruction of neutrophil elastase to go unchecked, thus damaging the alveoli and eventually leading to emphysema in individuals as young as 30 years of age. Another risk factor is people who are diagnosed with asthma and are still smoking. So this combination of asthma, which is a chronic inflammatory airway disease, as well as smoking, increases the risk of the patient developing COPD even more. Age is another contributing factor because COPD develops slowly over the years. So most people are at least 40 years old when they start noticing the symptoms. COPD was the 4th leading cause of death globally and accounted for more than 3 million deaths in 2012 in the United States. The prevalence of this disorder varies considerably in each country. Because the prevalence is based on the number of adults who have been told by a physician that they have emphysema, the actual number is thought to be much higher. Most people do not seek medical care until the disease is in its later stages. Women who are smokers in certain age groups are more than 38 times likely to develop the condition compared to women who have never smoked in their lives. Moreover, women are dying from this disorder than men. Now we'll be moving to the pathogenesis. Emphysema, it refers to the irreversible damage caused to the alveoli in the lungs. This leads to a dramatic decline in the alveolar surface area available for gaseous exchange. Furthermore, loss of alveoli leads to airflow limitations by two mechanisms. The first one, the loss of the alveolar wall, results in a decrease in elastic recoil, which leads to airflow limitation. Then the second one, the loss of the alveolar supporting structures leads to airway narrowing, which further limits airflow. One hypothesis is that the excessive amounts of the enzyme lysosomal elastase are released from the neutrophils in the lungs. This results in the destruction of elastin, which is an important structural protein of the lung. Neutrophil elastase also feeds type 4 collagen, and then this module is important in determining the strength of the thin sides of the pulmonary capillary and therefore the integrity of the alveolar wall. Animals that have had neutrophil elastase instilled into their airways develop histologic changes that are similar in many ways to emphysema. Cigarette smoking is an important pathogenic factor and may work by stimulating macrophages to release neutrophil chemoattractants such as C5a or by reducing the activity of elastase inhibitors. Many neutrophils are normally marginated or trapped in the lungs, and this process is exaggerated by cigarette smoking, which also activates trapped leukocytes. This hypothesis puts the etiology of the same footing as that for the emphysema of alpha-1 antitrypsin deficiency, in which the mechanism is the lack of antiproteins that normally inhibit elastase. One puzzle is why some heavy smokers do not develop the disease. Air pollution may play a role, as many hereditary factors, which are clearly important in alpha-1 antitrypsin deficiency. Smoke pollution from fuels, for example, from use of poorly ventilated wood burning stoves indoors, is now also recognized as an important cause of COPD worldwide. Now we'll be going into the pattern recognition for the disease. You can have emphysema for many years without noticing any signs or symptoms. The main symptom of emphysema is shortness of breath, which usually begins gradually. You may start avoiding activities that cause you to be short of breath, so the symptom doesn't become a problem until it starts interfering with daily tasks. Emphysema eventually causes shortness of breath, even while you're at rest. Other symptoms to be aware of is chronic cough, as well as a lot of mucus production, wheezing, fatigue, sleep problems, bleeding lips, or fingernail beds, cyanosis due to lack of oxygen, frequent lung infections, as well as fatigue. Disease progression. The gradual destruction of the alveolar septi and of the capillary bed in emphysema leads to a decreased ability to oxygenate the blood. The body compensates with lowered cardiac output as well as hyperventilation. This mismatch results in relatively limited blood flow through a fairly well oxygenated lung with normal blood gases and pressures in the lung, in contrast to the situation in chronic bronchitis. Because of low cardiac output, the rest of the body also suffers from tissue hypoxia and pulmonary cachexia. Eventually, these patients develop muscle wasting and weight loss and are identified as pin puffers. As emphysema progresses, the damage caused to the alveoli will eventually lead to decreased elasticity and hyperinflation. Swelling or air pockets called bullae develop, which will then trap the carbon dioxide. To track the progression of emphysema, tests and staging systems are used. One of the common tests is the pulmonary function test. So this test measures the lung volumes and capacities of the lungs. The gold staging system, which is the global initiative for chronic obstructive lung disease, came up with a staging system that uses the forced expiratory volume in 1 second, which is the amount of air that an individual can forcefully exhale in 1 second after a deep maximal inspiration. It places the emphysema progression into stages. So the stages are separated into 4. The first stage is known as the mild condition or stage, where the FEV1 is 80% or greater of the predicted. Stage 2, which is moderate, and the FEV1 is 50 to 79% of the predicted. Stage 3, which is severe, the FEV1 is 30 to 49% of the predicted. And stage 4, which is very severe, the FEV1 is greater than 30% of the predicted. Many patients will end up having to use oxygen therapy as a way of coping with the disorder. This is due to tissue hypoxia. Severe stages of emphysema result in death because of the complications that are encountered, such as respiratory infections, heart problems, lung cancer, as well as pulmonary hypertension. Now we'll be getting into the treatment. Because the disease cannot be cured, there are ways to treat it so that you can prolong your life and also make it easier to cope on a daily basis. So we have pharmacological ways and non-pharmacological ways to treat the disorder. So the medications that are used for this are bronchodilators. So these drugs can help relieve coughing, shortness of breath, and breathing problems by relaxing the constricted muscles in your airways. Inhaled steroids are also used. So these corticosteroids are inhaled. These include your aerosol sprays, which reduce inflammation and help relieve shortness of breath. Antibiotics are also used because these patients are prone to respiratory infections. So they will develop or might develop acute bronchitis or pneumonia. So the antibiotics will help with that. Other ways the patient I help through with that condition. So they undergo pulmonary rehabilitation, where they go through a program where they will teach them how to breathe, breathing exercises and techniques that will help reduce their breathlessness and improve their ability to exercise. Also, nutrition therapy. They will give advice on the proper nutrition that is significant to the disease. And then in the early stages of the emphysema, many people will lose weight. So this will also help them to gain weight. Another way of treating this is by using supplemental oxygen. So this is used where in stages where the emphysema is very severe because of the cyanosis due to lack of oxygen. And then some patients will undergo surgery. So it's either they will receive transplantation or they will undergo a surgery where they are parts of their lung where the tissue is dead will be removed so that they can breathe properly. All right, so now I'm gonna hand over to Jessica to continue.
Okay, so because we're running out of time, I think I'm just going to do the discussion by myself quickly. It's nothing too hectic. We'll just first look at the symptoms. The patient that I did the case study for had a productive cough, dyspnea on exertion, wheezing, night sweats, excessive weight loss, fatigue, and a hyperinflated chest. Many of these symptoms are characteristic of emphysema, which can be shown in the disease progression that patients did. For investigations and diagnosis, excuse me, there was a chest CT, spirometry, lung volumes, oxygen assessment, a BD response, blood gases, oximetry, and a biopsy. These are all ways that we can diagnose emphysema, which was also shown when patients was doing her side, so that was very similar. Treatment for the patient was salbutamol, which is a bronchodilator, theophylline, which is used to treat wheezing, dyspnea, and chest tightness, oxygen, Tiotropium bromide, which is also a long-acting bronchodilator. These are all treatments that were also explained by patients that can also be used. And the patient also had to undergo some life changes, such as stopping smoking, healthy eating, which is also in line with the treatment and diagnosis of emphysema. So to conclude, emphysema is a dangerous disease with a higher mortality rate. Avoiding risk factors such as smoking could be the difference between developing the disease and being healthy for many years to come. There are ways to treat the symptoms of emphysema to make quality of life better and to make it easier to live, but unfortunately, as we have said many times, it cannot be cured or reversed. Then we have some references here for our pictures and our information. And thank you very much for listening.
Thank you.